Yeah, so fallen fragment sign. Yes. So if you describe it and you want to put like differential diagnosis, what is your differential? And what's the most important when you describe it? So you will mention that leucent lesion in the left humerus, and you mentioned that centrally located. It's good to comment in the cortex. You can see the cortex here, and there is thinning of the cortex, right? And there is expansion as well. And maybe it's good also to comment and mention that there is some internal septation. Yeah, Huda, perfect. So good to mention that it is have narrow zone of transition. And when you see this sign, you will mention that this is one is the fallen fragment sign. Your differential diagnosis will be aneurysmal bone cyst. But with this sign, it will go to simple bone cyst, as we know. The aneurysmal bone cyst, it comes in age of 10 to 30 years old. It like the metaphysis and plus the epiphysis. So it's a bit different. Yeah, Marwa, nice. So it is the same, but maybe the cortex will be maybe intact, expansile, the same expansile. Okay. Maybe I can show you something now. And the second differential will put the giant cell tumor, but the age again is not typical because the age, you know, it is more than 20 years old, and it like the subarticular location, right? So this one is more to be simple bone cyst. Other differential you can put like brown tumor, fibrous dysplasia, and in chondroma. Okay. So let's see the MRI for some patient. I think this one. Yes. So this is the MRI. You can see the very high signal in the T2 in MRI. And I think if I show you this one, it will be, yeah, fluid signaling. So what do you think about this one? You can see here. Yeah, in the left iliac bone, leucent lesion. Again, when you describe it, you will mention that narrow zone of transition, and yeah, it have differential diagnosis, and this one was aneurysmal bone cyst. Yes, non-sclerotic border. Okay, let's go to this case. Sorry. So this patient is like 40 years old male patient with left hip pain. I think this one is easy one. Yeah, ankylosing spondylitis. So what are the positive signs here of ankylosing? And dagger sign, Marwa, Fawzi, Ibad, there is.
Ischemic encephalopathy.
Okay. So
right avascular necrosis, replacement of the right femoral head.
Yes. Okay, so at least there is maybe the sacroiliac joint here, you don't see them, but with this at least dagger sign and you will suspect that there is fusion, right? And there is interspinous ligament ossification as well. And here some arthropathy in the symphysis pubis. So ankylosing spondylitis. I'm fine. Inshallah. شكرا دكتور فوزي. Okay, let's try to show you this one. The same patient. Yes. So you can see something positive here of the ankylosing spondylitis signs. What is positive here? Shiny corner or Romanus lesion. Yes, perfect. And what do you think about here? شيماء, yeah, هدى, Justana, Marwa, perfect. So again, here you will find the sacroiliitis and maybe some erosion and sclerosis. Nice. Perfect. Symmetrical sacroiliitis. Until now is easy cases. I like to start with easy to open your appetite. And then we go to the heavy meal after a while. Okay, this one I think is easy again. You remember the line? Left slipped capital femoral epiphysis, perfect, Marwa, Justiana, is easy one. And you remember the line you wrote always in the scaphy, in the Klein line. So you should intersect part from the upper, yes, femoral epiphysis, Doc Mansour, okay. So when you don't intersect like here anything, then it is scaphy, and it could be bilateral. You remember our discussion before about it. The best location will be the frog leg, which accentuate the slipped capital femoral epiphysis. And this is the line, if you remember. Yes. Okay. Let's go to this one. This patient have pain in the amputation stump. So what do you expect? Let's try to describe it. Marwa, bony lesion. So where is the bony lesion exactly? Permeative moth-eaten bony lesion. Try to characterize the location. I want like a model answer. It's good that you make good start. Very nice start, by the way. So permeative, yes.
The remnants of tibia.
Okay, perfect.
And also the fibula.
So yeah, so you see that the density here of the bone is not well. So permeative lesion, and you will mention that wide zone of transition or narrow zone of transition. They like it in the description. You should be careful about this term. So
it's aggressive bone lesion.
Yes, perfect. So wide zone of transition, then you will mention that it is aggressive bony lesion. And maybe also the fibula have similar appearance. So what do you expect then of permeative bone lesion? I see some recurrence, so you consider it as primary tumor, right? Or osteomyelitis as infection, perfect. I see some suggestion like
leukemia, lymphoma, metastasis.
metastasis, perfect. And in this age, maybe you can mention also myeloma. So yes, it was lymphoma, relapse lymphoma following amputation, and the nice differential you put is very nice. And you can consider that the soft tissue here also have increased density. Yeah. Okay. I want to show you something else here. So try to maybe to describe it. So this is a fat suppression, and what do you think about the appearance of this appearance?
Multiple infiltrative marrow lesions.
Yes. So
With cortical disruption and some edema at the adjacent muscles.
yeah, so this is the most important to mention. Again, destruction reaching the cortex as here. Wide zone of transition again. So perfect explanation, yes, Fawzi and Marwa, Shayma, yes. Again here, if you, for the aggressive bony lesion, for example, this one again, permeative lesion and wide zone of transition, and you should comment is reaching the cortex or not, and maybe if it is near the articular cartilage, you should mention it is have interarticular extension or not. So again, the same differential. Yeah, if you suspect like tumor, so it will be referral for MDT team. Yes, okay. Let's have this case. I think I share one similar to this case in the group. 4 years old, presented with suspected chest infection. Then differential diagnosis.
Generalized increase in bone density in pediatric age group.
Perfect. So this is the big title you will search for, and you will put the first top of your list.
Osteopectrosis, pycnodiastosis, fluorosis, hypervitaminosis.
Yeah, osteopetrosis, pycnodiastosis, renal osteodystrophy.
And renal osteodystrophy.
Perfect. And fluorosis and hypervitaminosis. That's nice. So this is the important. I see that. Let's go to the similar again and again. Increase density, but with pathological fracture. This one, it was pycnodiastosis, for example. And if you look in this one again, but this one have something more, maybe you can.
Erlenmeyer flask deformity.
Yeah, Erlenmeyer flask deformity. So do you remember the differential of when you find this flask deformity shape?
Metaphyseal thalassemia, osteopetrosis, Gaucher.
Perfect. Then you will start again with
Bile disease also.
yes, yeah. Perfect. So we'll start maybe with the Gaucher-Niemann-Beck osteopetrosis. Maybe you will start with osteopetrosis and
lead poisoning.
Lead poisoning, perfect. So we'll start with lead poisoning, Gaucher-Niemann-Beck, and osteopetrosis, metaphyseal dysplasia, and thalassemia. Yes. And there is one, yeah, metaphyseal dysplasia or something called bile disease. Yeah. Maybe I will show you something more. Yes, here. So this pycnodiastosis, and you can see that they have again osteosclerosis and you have in the distal phalanges something called pointing. Yeah, pointing of distal phalanges. Like you can consider it like pointed chalk appearance. Okay. Again, in the forearm with fluorosis, you can see the increased bone density, especially around the ligamentous insertion and calcifications. Okay. Let's go to check this case, which I think for you it will be again easy. So 60 years old female presenting with neck pain.
Atlantoaxial subluxation.
Yeah.
Juvenile rheumatoid arthritis.
Perfect, yeah. You will suspect rheumatoid arthritis, and this one, it will be atlantoaxial subluxation. Perfect. So
Facet ankylosis.
sorry, what?
Facet ankylosis.
Yeah. Okay. So the differential diagnosis will be rheumatoid, as you mentioned. What else you can include as a causes for this appearance in general?
Ankylosing spondylitis.
Yeah, ankylosing, maybe systemic.
Juvenile rheumatoid arthritis.
Juvenile, perfect.
PPPD.
Psoriasis, yeah.
Retropharyngeal abscess.
Yes, retropharyngeal abscess. And let me show you something in MRI for the atlantoaxial subluxation. Yes, so what happened here with this patient? Can you describe it? What happened with, again, this patient with atlantoaxial subluxation? What he have here?
Erosion of the dens with panus formation.
Yeah, so he have this appearance that you know that this patient have erosion. Perfect, Shayma, Huda. Nice, Marwa. I see that many very nice answers. So and if you go to the same patient feet, then you can find that already he have like a lot of signs of rheumatoid arthritis. Okay. I see that everyone is going well with this. Maybe we can shift another shift now. I hope that you like it. So let's go with this one. So try to activate your checklist, and when you reach something like you don't know where exactly, you try to talk until you reach the abnormality. So frontal radiograph, maybe adult male patient. So you will try to reach anything positive. Maybe the lungs, you can see that they are clear, and the cardiac and mediastinal contour is okay. So what is missing here in your checklist? You will find it. You try to find the big title. Yes. So ribs. What you want from the ribs?
Inferior notching.
No, it is not. I mean that if you want to show you this, it will be maybe more obvious. Search for something else. It is in the bone, yes. So what do you like the bone density? Again?
Increase in density, yes.
Yes, increase in density. Then try to put this in the big title now, diffuse density, increase density. So myths from what? Maybe breast cancer, maybe prostate cancer, maybe. Okay, then you will, if you consider like myths, you will search for anything else like lung nodules. Yeah. So if it's not myths, what else can make this appearance? Yes. Could be, yes, Gistiana, it can be sickle cell disease. Then you will search
No,
for the
right.
signs of sickle cell disease. So what are the signs? You can search here. You can start with,
overriding
yes,
vertebra and
sigmoid flexion, splenic flexion.
yeah, you'll find if there is any splenic calcification. Then you'll go to the vertebra to search for any central depression, H-shaped vertebrae, and go to the humeri, any bone that you can find if there is any vascular necrosis, and the cardiac size if there is any cardiomegaly, and if there is any gallstone in the right. Yes, so perfect. So here we can mention that there is maybe increased bone density and there is central depression, which is very subtle, but maybe if you try to trace it, maybe you can find it, and at least you can search for it. Okay. So what else will be the differential? Will be something like osteopetrosis. We mentioned it, but this is in young age, in pediatric age group.
In adult renal osteodystrophy.
Perfect, Marwa. Renal osteodystrophy can happen either in child or in adult, so but it have appearance of Ruger-Jersey spine, subperiosteal bone resorption. You will search for these things, and in the history of this patient, you will search for any hemodialysis. Yes. Okay. There is also one rare. Maybe you can mention it as end of your list. Something called myelofibrosis. Then you will go to look in the spleen again, and you expect that you will find splenomegaly or autosplenectomy as sickle cell. You will find splenomegaly, yes. But maybe you can find surgical clips, maybe if this patient did splenectomy. Okay. So large spleen, myelofibrosis, they like it in the exam, sickle cell disease. Let's just to go to the, yes, next case. Yes. So try to focus in this one. And try to describe, so frontal radiograph, pelvis of adult female, sort of adult, whatever. You will find, try to find the big title. Yes, could be. So is it focal or diffuse?
There is a lucency in left femur.
Is it focal or diffuse? Yes, so it is a bit, yeah, already the patient have like osteopenia. So this maybe make the background multiple. I see Marwa. Yes, very nice. Multiple lytic lesion with endosteal scalloping with fractured left femur. Perfect. So multiple lucent lesions. This is the big title. you will start to search for the diagnosis or differential diagnosis. Multiple myeloma will be the top, and metastasis. So metastasis, multiple myeloma. So if it is metastasis, it can be like this: multiple myeloma with industrial scalloping. If it is not specific, but you can see it. So yeah, multiple myeloma, it will be one of the good differential. Other differential can be, yeah, Marwa, brown tumors. If younger, can be fibrous dysplasia, about below 30 years old, so you should be younger. And it can also some have like Euler's disease or Mafushi enchondromatosis, but it is not the top list. So the top list will be metastasis and multiple myeloma. Okay, perfect. Oops. So okay, we show the answer, but we can try to make a good answer for this. So what do you think? Pelvis again, adult pelvis. Is it multiple or single, lytic or sclerotic, expansile or not? You should fulfill this. Then don't forget narrow zone of transition or wide zone of transition, and look like aggressive lesion or not aggressive lesion. Yeah, so when you fulfill this criteria, you will find for anything aggressive like destruction. Yeah, perfect, Rabab, Shayma. So you will think that could be metastasis. I see, Shayma. Yeah, it can be metastasis. It can be metastatic. There is cortical breaching, and can be metastasis. Then the question will be, if it is lytic lesion metastatic, which tumor would be the primary? Yeah, renal, thyroid. So CT, MRI, C will be T, thyroid, M, melanoma, R, renal, and I, islet. Yes. So it can be CT, MRI. Yes. So it is metastatic. It was metastatic from thyroid cancer. Let's go to this one. Yeah, melanoma, lung. Perfect, Marwa. Again, the same wide zone. Yeah, nice. MacBook, wide zone of transition. So your first impression, it is aggressive lesion. The location here is very important to mention that it is metadiaphyseal. There is cortical breaching and cortical erosion. Yes.
Osteosarcoma.
Osteosarcoma will be the top of your differential. Perfect. So it is aggressive, mainly lytic, and you can see some sclerosis here. So mixed. It will be the differential Ewing, doc, perfect, Ewing sarcoma, osteomyelitis, you can put it, and maybe eosinophilic granuloma or Langerhans, maybe, but not like more likely. You can put it with less likely. So leukemia and Ewing metastasis, eosinophilic granuloma, and sure that osteosarcoma will be the first. Osteosarcoma from 10 to 20 years old, metaphyseal. It can mix with lytic and sclerotic behavior. The most important to mention the periosteal. If you find any periosteal malignant looking periosteal reaction, and if there is any associated soft tissue mass, maybe in the MRI will be more, yeah. And if this patient do something like whole body, you will mention that you will search for skip lesions. Okay. CT scan, selected images, single or multiple. The location will be nice to mention. Then lytic or lucent or not. Also the matrix, you can mention if there is any foci of calcification or not. Then the narrow or wide zone of transition, there is any periosteal reaction, cortical breaching or endosteal scalloping. So I see Shayma, yeah, it could be lytic lesion. The location is important. There is sclerosis of the margin. So continue back. Okay. We are coming back. So we were talking about the description, and you mentioned that it is in the proximal tibia, right? And maybe it's good to mention that it is in location is epiphyseal, right? So then maybe now it will be easy for you to put, yeah, there is some internal matrix calcific foci, and you will put sure that differential diagnosis will be giant cell, maybe, and osteomyelitis as possible differential diagnosis, but the chondroblastoma will be your first top list differential diagnosis, chondroblastoma, because this young patient and it is epiphyseal lytic lesion, so it will be chondroblastoma as first diagnosis. Brutus maybe. Okay. So chondroblastoma it will be the first differential diagnosis. Let me show you something in this patient. Yes, the MRI of this patient, this is like some selected images in the tibia, and I think it's good to describe it again with marrow edema, nice, and the rim is sclerotic. And yeah, so that's why the infection will be one of the good differential for this case. Yeah, marrow edema, sclerotic rim, but maybe as you see, the CT will be more helpful here. And yeah, there is some soft tissue reaction, but if we go to the contrast, we will not find like soft tissue mass, no enhancing soft tissue masses. Maybe some edema in the surrounding soft tissue, but no soft tissue mass. Yeah, perfect. Again, this T2 MRI, and here you can see the T1. So what is the big title you will put when you find this? How we describe it? Sagittal T1, T2 MRI. Yeah. Diffuse low signal intensity in the bone marrow. Yes. You compared it, Marwa, for the adjacent disc. So when it is lower than the adjacent disc, this means that it is pathological, right? So bone marrow infiltration and the signal intensity of the bone marrow less than the. So heterogeneous low marrow signal through the lumbar spine and even the sacrum. Yeah. So the differential will be lymphoma, leukemia, myeloma, metastasis. Perfect. So metastasis and myeloma, multiple myeloma, lymphoma and leukemia. And if you mention lymphoma, then it's good to mention that you will search for any associated lymphadenopathy, splenomegaly, and so on. Yeah. Perfect. So we need a stair. Oh yes. Fat suppression. Yeah. Extramedullary hematopoiesis. Yeah. Then it's good to mention now that maybe mastocytosis and myelofibrosis will be one of good differential. Then again, you will search for the splenomegaly. And if you find this picture of splenomegaly with marked splenomegaly, then you will suggest that it will be myelofibrosis. Perfect, Justiana. Perfect. So it will be myelofibrosis, one of the good differential. Okay. This one, you will try to make model answer with plain lateral radiograph of lumbar spine, adult patient. Thank you, Marwa. I see your answer in the last case about myelofibrosis. You need stair to differentiate edema from sclerosis, unless a stair is given. Yeah, because the stair is very sensitive for the edema, right? For the fluid signal in general. So it will be very high in the stair. Okay. Let's go to this case, and we try to make interpretation. So you will try to find any abnormality in your checklist. So the big title will be posterior scalloping of the lumbar vertebrae. Thank you, Justiana. Posterior vertebral body scalloping. Then your question will be, what is the differential diagnosis? So they like to mention Salomon. S for spinal cord tumor. This is make like maybe more localized form of scalloping, especially in the interpedicular. Yes. And A, what it will be referring to is very
Achondroplasia.
achondroplasia. Perfect, achondroplasia. Then you remember that you will search for the criteria of achondroplasia, like short pedicles in the lumbar spine. in the sagittal view and with spinal canal narrowing and maybe progressive narrowing of the interpedicular distance as well. Perfect. Anterior vertebral body peaks sometimes, champagne glass if you have pelvis, horizontal sacrum and tombstone iliac wings. Yeah. Mucopolysaccharidosis. So this is the M of Salomon, will be mucopolysaccharidosis, Morquio type maybe, and Marfan syndrome as well. N for N, neurofibromatosis, perfect. And O for osteogenesis imperfecta. So nice, perfect. So this one was achondroplasia. We mentioned the criteria already. The pedicles are truncated or narrowed, the spinal canal narrowed here. And there is no any destruction in the bone, so no tumor. The posterior body.
Is also horizontal sacrum.
Horizontal sacrum, perfect. The pedicle we mentioned that is shortened. So the achondroplasia will be the best for this case. Caudal narrowing also of the interpedicular distance. Okay. If he show you the pelvis, then maybe you can talk about the tombstone iliac wings, champagne glass pelvic inlet. Okay. Frontal radiograph, adult, maybe you can mention that is female because you have breast here. And search for your checklist until you find any positive. Maybe the lungs, I will try to help you, the lungs clear. Cardiac and mediastinal contour is okay. In the esophagus, if you check it, not dilated. The retrocardiac is fine. The shoulder is not sprinkled, maybe just positional. There is clear costophrenic angles. There is no effusion in the pleura. Yes, Ala. Welcome, Ala. I don't know if it's your first answer, but Nermin also, I don't see Nermin today. But at least we have, yeah, distal erosion, Marwa, perfect. Yes. So Ala and Marwa, our big stars for today, we have distal clavicle erosions. Yes. Put it in your active list, then it's easy for you. Then now your role to, yeah, rheumatoid arthritis. To say this is the R of shirt. Shirt is like the word you remember the differential diagnosis. So R, rheumatoid arthritis. If it is rheumatoid arthritis, you will search for erosions and joint space narrowing, especially for the glenohumeral. That's why maybe that there is something, yeah. And you will search for any lower loop fibrosis if you mention rheumatoid arthritis. And finally, you will search for any avascular necrosis. All this in rheumatoid because the patient takes steroids. Yes. Okay, and the hyperbara, I see Ala take hyperbara. So you will search for, and if it is hyperpara, you will search for sclerosis and brown tumors and soft tissue calcifications. Perfect. So the H for shirt, it will be the hyperpara, infection like osteomyelitis, if it is one side, but this one, it is both sides. Rheumatoid arthritis, we already mentioned. Trauma, post-traumatic osteolysis for the T. And S for what? Marwa, yeah. Scleroderma, then you will search for dilated esophagus, and again, lower lobe fibrosis and soft tissue calcification. So scleroderma, hyperpara, infection, rheumatoid, and trauma. So this is the differential of the distal clavicle or lateral clavicle resorption. Okay? If you will ask the examiner for something, maybe you can ask him for hand, then check if it is going more with rheumatoid arthritis, scleroderma, or hyperpara. Okay? Is it clear? I see very nice answers. Perfect. This one, I think it will be easy for you. Or big stars.
Small force metacarpal.
Short metacarpals, yes.
Pseudo hyperparathyroidism.
Pseudo hyperpara, yeah. The first one in the list. So what others in the list you can put? Pseudo,
Turner.
yes, pseudo hyperpara. In the pseudo hyperpara, you will search for intracranial calcifications. Turner, so TIPS, perfect. Huda, Rabab, Turner. So Turner for, you will search maybe for mud lung deformity, if it is present.
Gorlin syndrome.
Yes. So you will search for
Dural calcification.
maybe. So it can be also idiopathic, maybe infection as well, yeah. Sickle cell disease, maybe post-dactyly. Trauma, infection, perfect. Pseudo hyperpara will be top of your list, especially for the exam. If this patient
It's a spot for the pseudo hyperparathyroid.
pseudo
Yes,
hypo,
it's a spot.
sorry, yeah. Pseudo hypo, yeah. Pseudo hypopara and pseudo hypopara. Yes, it is not hyper. Sorry.
Hypo.
Hypo, yes, hypopara, yes. And you will search for intracranial calcifications. Pseudo hypopara. So there is shortening of the fourth metacarpal, no associated mud lung deformity, everything otherwise clear and normal. The patient didn't have anything like trauma, surgery. So then you are going to mention that it will be pseudo hypoparathyroidism. Yeah, okay. If this patient is like female, maybe you can
Turner
consider
syndrome.
Turner, yes. So let's have a look in this case and try to find the big title.
Erosive osteoarthritis.
Maybe if we start with the description is easier, then you can find it. Yes, Ala, I agree with you. I see also Mansour. Perfect. Welcome, Mansour. New star or new star here. Okay. So acrosteolysis will be the big title. radiograph both hands, bone resorption, look in the tufts. Okay, so one of the top list you'll put scleroderma and
Hyperparathyroidism, DD, differential hyperparathyroidism.
okay, and you will search for any soft tissue calcification.
Yeah.
And if there is any periostitis, yes, and the bone resorption, acrosteolysis, scleroderma, soft tissue calcifications, if there is, you will try to find the, as you mentioned, Fauzi, that erosive arthropathy, sclerodactyly, and the contractures. Trauma, diabetes, Huda, trauma, Ala, frostbite, psoriasis, Marwa, perfect. Nirmeen, welcome. Scleroderma, soft tissue calcification, doc. Okay, so scleroderma, let's summarize. Scleroderma will be symmetrical, erosive, distal arthropathy, maybe like here, but there is some other signs like penicillin cup, periostitis, periosteal bone proliferation, new bone formation, and maybe nail changes, and finally bone enclosing. Yes, welcome, Nirmeen. Then injury, infection, as you mentioned, one of them it will be the frostbites or burns. Neuropathies, diabetes, as you mentioned, and hyperparathyroidism. The subperiosteal reabsorption, especially in the radial aspect of the middle phalanges. But you will search for brown tumors, osteosclerosis, any calcification, the same. If there is any further you will do, you will search for the history of this patient, any previous imaging. If this patient have esophageal dilatation or lung fibrosis, upper or lower lung fibrosis, it will be basal or upper fibrosis in the lung, lower, perfect. So this is what criteria you will search for, and you will mention in your exam. Yes. Here is easy one. Young child, the age important. Your differential, so your top list will be differential, your B, neurofibromatosis. So what happened here? Abnormal curvature of the tibia.
Bowing and pseudoarthrosis.
Pseudoarthrosis, perfect. Bowing with pseudoarthrosis. So what is your differential?
Neurofibromatosis.
Yeah, first. And you will search for any criteria like fibular hypoglysia and
Multiple bone.
pathological fractures, pseudoarthrosis, as we mentioned, and if you go other abnormalities like ribs will be ribbon ribs, posterior vestibular scalloping, sphenoid wing hypoglysia. The other differential they like to mention when you just find bowing, it will be the Paget, rickets, osteogenesis imperfecta. Yeah, some, but in this case it will be maybe neurofibromatosis as for first differential. Okay, the other differential will be less likely. Yes, osteogenesis imperfecta, rickets, Paget, not in this age, and maybe Blount disease. What else? Idiopathic. Yeah, achondroplasia, maybe achondroplasia, but achondroplasia will be shortening of the long bones, not like here, so it is a bit different. Okay. This one is a common, famous one. Let's try to find it.
Cruising cyst.
So radiograph of hand, and you can see that he focus in the thumb. So you will try to describe it.
And content.
So is it a solitary or multiple? Yeah. So you consider it as a solitary or multiple, maybe solitary, lytic or sclerotic, to be lytic. Then you mention the site, and the most important to mention that it have cortical breaching, little expansile, so like a bit aggressive type, right? Search for any periosteal reaction or soft tissue associated, then you can confirm that it could go with more with aggressive behavior versus the non-aggressive behavior, right? So do you see any periosteal reaction or any soft tissue? I see subarticular giant cell metastasis. Yeah, can be metastasis, perfect. Can be giant cell. So you will think about maybe metastasis, perfect. No soft tissue association, no, yeah. Maybe just some periosteal reaction here and cortical breaching. So if it is metastatic and aggressive, which cancer can send this behavior? Lung cancer, you will put it the most common one. And if it is have diffuse periosteal reaction, then you will think that it is like paraneoplastic syndrome or hyperostosis, hypertrophic osteoarthropathy. Yeah. It can happen from any tumor, even like pleural tumor like fibroma, mesothelioma, cyanotic heart diseases, perfect. And cirrhosis, this patient have liver cirrhosis. So the first will be the lung cancer, and this one will cause metastasis from lung cancer, and there is some periosteal reaction as well. Okay, last case in this, before we shift to another stage, the final stage. So I think this one is easy one. Try to describe. It will be plain radiograph, pelvic, adult patient. The big title you will put that it will be patchy sclerosis of femoral. I see the differential, nice differential, Shayma, Doc, Justiana. So patchy sclerosis or sclerosis of both femoral heads.
Yeah.
So you will
Sickle
put
cell
a vascular necrosis as top differential. Then you will search for the criteria, the other criteria for a vascular necrosis, and then the cause of a vascular necrosis. Perfect. Here there is maybe subchondral lucency. Maybe there is flattening in the right femoral head. You will mention the joint space is almost like spared. This is important to mention. Then you will search for the cause. Patient history is more important. So what it will be the cause? If it is steroids, you will search for renal transplants, associate, perfect. If it's the alcohol, you will search in the X-ray for the abdomen, pancreatic calcifications, perfect. If this patient diabetic, you will search for any vascular calcifications. Then sickle cell, we mentioned it before. Yeah, with this criteria. Trauma.
Inflammatory bowel disease. Yeah.
Yeah, can you make your voice more louder than we can? Yeah, sickle cell, yes. Trauma, infection, births, you mean births, right? If it is young, if he's pediatric age group, you can mention births. And something called Gaucher disease with, again, massive splenectomy, bone marrow infiltration, and it have many Erlenmeyer flask deformity, osteopenia, H vertebrae, so similar to sickle cell, but with marked splenomegaly, Gaucher. So this is the causes of avascular necrosis. Okay, so maybe I can show you now the cause in this case was, I will show the MRI, and then you can try to, the easy one.
Doctor, is there any SI joint obliteration?
Sorry, what?
Is there any SI joint or obliteration in this pelvic X-ray?
You think transplanted kidney?
Okay, I will come back in this, but yes, the transplanted kidney in the left iliac region. So this patient, for the transplanted kidney, he take like steroids and other immunosuppressive drugs, right? So that's why he have this appearance, right? So this is avascular necrosis. Maybe you can check, but I think maybe from the exposure, maybe it's not very clear that he have something in sacroiliac, but maybe, I'm not sure.
Yes.
It is
Yes,
like
thank you.
images. So transplanted kidney. Okay. Then finally, I think we now about to reach the final stage today with one case of, and the question will be a very easy question. I wish that you will enjoy it. So what is the difference between patient, he's the same patient by the way, so what is the difference between here and here? So let's talk about that this patient have primary like breast cancer and he have treatment. So yeah, this is what they like you to mention, that he have complete metabolic response, perfect rabot. So they have CMR. CMR mean complete metabolic response. So he was having liver metastasis, as you see here, and you can see that he have osseous metastasis, and also you can see that he have some lymph node metastasis, right? Then when he did the follow-up PET-CT, then he have what is called complete metabolic response. Is it easy? Okay. Okay.
Not easy.
Not very easy, but okay. I make the dose very light today. Then we can make it more conventional than hybrid imaging. So again, this patient have something before and something after. So that's mean that he have like treatment and it will be post chemotherapy. So this one prior to treatment for the initial staging, then he did this after treatment. So can you see the differences? So the uptake here in the bone was very high. Do you agree? And in the CT, is it was lytic or sclerotic? Yeah, it was lytic, and this patient after treatment, can you see that the uptake gone, and the lytic becomes sclerotic. So this is what like healing. So again, this patient have complete metabolic. Why metabolic? Because you see that the uptake, the tracer uptake, which is a metabolic criteria, it gone, it end, it finish. You don't see it here. So this means that it's good response, which is called metabolic, good, complete metabolic response, or CMR. Okay? And in the CT, you will find some sclerosis. So this means that it is going to go to healing. Okay? Healing. It's good response, and this patient have healing. So back to this case again, because maybe you can see that the metabolic response is high here. Then here it gone, you don't see it. And here the lesion was having high uptake, but the sclerosis was less. And when the healing happened or the response happened, you can see the sclerosis become more, right? But when you see go to the metabolic activity of this lesion, it is finished, or you can say it is decreased, much decreased. So this means that this patient going in healing. And you can see here the MIB image of the previous PET-CT and the current PET-CT, and then you can imagine the good response that we have 1, 2, 3, 4, 5, 6, 7, 8, and here you cannot count anything. This is physiological, and this is physiological, and this is physiological, okay? And the urinary bladder again, excretion. So I think now maybe it's a bit easier to know that PET-CT is like good for your response. You can is requested to assess the response in this patient. And again, I think here this patient, he did like restaging PET-CT after he already did treated by lumpectomy for breast cancer and take chemotherapy. So what do you see here?
Internal memory lymph node, likely recurrence.
But the internal memory maybe is here, right? It should be like in the typical location, it is here, in the beside just the internal memory artery. So maybe if you mention that is subcutaneous, maybe is more, yes, high uptake. So maybe chest wall, or you can mention subcutaneous, right? And they like to show you this appearance. So this physiological or pathological? The ideal answer that you can say to me, it can be both. If it is pathological, you will go to check the axial images and see. But this one, it is physiological because sometimes the ovary and the uterus can have normal uptake. Yes, it is ovarian. This one is ovarian, and this one is uterine. So it can have normal uptake, even as you see that the patient didn't have any metastasis. That's why. But it can be pathological, sure, if this patient, for example, have metastasis in the ovary with Krakenberg. But to be honest, it is very high uptake. In these cases, you have much high uptake, and probably you will find other metastases. Okay. We have 2 minutes. So again, this patient have A and B. So when you have this previous and current, so this is like follow-up. Dr. Fauzi, we will mention like every time, inshallah, we'll take like very few cases. If you like this system, we will make like a bit stable for a while. Until every time we'll take like very few cases of this type and show you until you become more familiar with the interpretation of this type of case. Okay. And I ask your suggestion in the group, but nobody sends suggestion. So please, I will ask you again. Anyone need discussion, please send in the group. Then we make this group to make it fruitful discussions together. Yani if you need any cases, anything, so send in discussion. We can. I don't know anything. I mean, we want to know your feedback. Then we can improve ourselves. And I, to be honest, I learn from your points. So this make me improving with you. Okay. So let's go to this case and see that this patient have something here. Then maybe you can say that first impression, is it nodal lesion, lymph node, or it is soft tissue? Maybe lymph node. Do you think so?
Yes.
Maybe. So if it is lymph node, so we can see what happened here after the patient take treatment. So you can say that this patient have regression, right? If it is lung or pulmonary lesion, whatever the same, it will be regression. If it is metastatic pulmonary nodule, yes. So what happened here, that just he wants to show you that this patient did treatment or retake treatment, and after that he have regression after he take the treatment, right? Okay, easy, is it easy? And you can see until we collect the finding, and finally we, or hopefully we can reach diagnosis. So what do you see here, abnormal? Can you analyze it? So I see that maybe there is a soft tissue lesion here. Do you agree with me? Yeah, enhancing lesion in the chest wall, maybe in, maybe you can mention that it is in the upper part, yes. Subcutaneous, maybe, and so maybe in chest wall. And do you agree that there is, you need to see the lung? I see Marwa and Nermeen that you need to see the lung. So let's shift and try if we find some. Okay, I don't think that he have any lung here, but okay. Okay, so let's go with the image. Maybe we collect the finding and see. So let's try to analyze the CT image. What do you think about them? I see that maybe, do you agree that the spleen here is not normal? It has some pathology. And if you look here, yeah, you can see that the site of the maybe right suprarenal and left suprarenal as well is involving. So bilateral suprarenal masses, spleen, and yes. And if you go to the uptake, you will find that there is high uptake involving the liver and spleen. But as you know, from we discussed before, that maybe the liver uptake is physiological, it's high. Then you need to find something focal to mention that it could be pathological. Yeah. Yeah, sometimes, yeah, it can, the metastasis or the abnormal metabolism can involve all the liver, but as a common, we can consider the liver uptake as physiological uptake, okay? And regarding the spleen, if it is diffuse uptake, maybe abnormal. Do you find anything abnormal here in this image before we shift? So at least there is chest wall lesion, and until now there is bilateral suprarenal lesion. The spleen may be involved. The lung is not healthy. Regarding again the physiological uptake of the colon and small bowel, sometimes we mentioned that it can be physiological. And regarding the urinary excretion as well. Okay. Let's have a look again. So now again, maybe there is focal uptake in this area. Let's see if we can find in the CT something. So again, suprarenal. Now is better. You can see the liver now. What do you have here? Multiple focal lesions. This is the MIB image, or maybe the coronal, one of the coronal images of the bit, just the bit, in the gray scale mode before inversion to the white black scale. So your differential, what it will be, again, could be lymphoma. Do you agree? Lymphoma can involve the suprarenal, can be metastasis. If it is metastasis, you will search for primary. Yes, nice. And I want to show you this also. Metastasis can be lung cancer, then you have to search for lung, because especially when you find the suprarenal. Maybe this lesion here is not right suprarenal, maybe here in the liver as well. So this case was a bit interesting, that it was one of the cases of metastatic melanoma to the liver and spleen. So the spleen as well is involved with diffuse uptake. And also you can see in the axial image, it's much obvious with the splenic involvement, and the CT as well. I was preparing to take something in head and neck, but maybe I will, okay, I will shift. So this one, for this case, okay. Let's go to another case. Try to describe. So right upper lung mass. Marwa, thank you. Speculated nodule, pulmonary nodule. Okay. Ala. So rounded lesion, speculation. Again. What you find in the bit, is it high uptake, low uptake? What do you think? Yeah, it's a high uptake here. So number one, mass in the lesion in the lung with high uptake. So what it will be? until proved otherwise, what it will be. Yeah, differential diagnosis, and you will put in the top of your differential pulmonary or bronchogenic cancer. Yes. Bronchogenic carcinoma. Maybe in the axial here, maybe there is some lymph nodes. Again, have high uptake. Yes. So this one I think is easy with right upper lobe lung cancer, small nodule, but it is high uptake, so it's lung cancer. Okay. Okay. So let's go to this case. Let's start with this image. What do you see here? There is high uptake here, which is look like a pathological. It is in the lung level still, so maybe something in chest wall. Maybe you need more images, right? Let's go to the CT image and try to collect the finding. So lung again. Do you see any abnormality here? So maybe bilateral nodules, maybe the largest one in this image here, or maybe, I'm not sure, this could be like a nodule, but maybe. Okay. In the other images, you can see that there is, again, multiple nodules. So what is your thinking now? And one of them was this one. So if we go to the first image, okay. Let's just stop here before we go. What do you think about this image? There is nodular thickening. Where this nodular thickening, it is yes, interstitial, some interstitial with nodular thickening, interlobular. Yeah. So now you think about pleural based. Okay, let's check more and see how we can solve this. Some of them are pleural based nodules. And if you go to the mediastinal window, I think it was this one. What do you see here? How do you solve it? Yeah. So again, chest wall mass, including pleural and maybe pericardial as well, thickening, and maybe lymphadenopathy. Okay. Differential diagnosis, mesothelioma, metastasis. Okay. Metastasis from where? Do you agree that maybe we can include lymphoma as well? In differential, maybe? Yes, okay. So it can be lymphoma and mesothelioma and metastasis. So if we focus on metastasis, which metastasis you would like to, what will be the primary? Yeah, what it will be the primary? Perfect. It can be bronchogenic, it can be breast metastasis, one of the most common. So if I told you that this is this patient is a female and she have already like left breast mass, so do you agree that it could be like metastasis from left breast cancer? You can see also the peritoneal nodules or peritoneal invasion. He won't show you the bone metastasis, maybe. So including the lung, the pleura. So there is pleural metastasis and lung metastasis in this case. Yes. So this what it was. It was breast cancer. Yeah. It was breast cancer and sending metastasis to lung and pleura. Okay. I was preparing to go in the images in the cases with the basis of systems. So I will show you, for example, we're first scope today to start head and neck again, but with the view of hybrid imaging. So let's start with you this case. Then we try to collect finding and reach something. I know that it will be a bit difficult than the previous what we used to make the conventional images. Can we try? At least we can try until we be familiar with this image. Okay, so how you describe this appearance in the CT? Is it like lymph node, or you can consider it as a mass, or and when you start to consider it as a mass, how you describe it? So left neck mass. Is it? Do you think that this one is from the bone? Do you agree this? I think is not a bone lesion. It looks like a soft tissue, right? Soft tissue lesion. Then, Rabab, you start to characterize where the site, the location. Maybe a submandibular extension. So you think that maybe it have lymphadenopathy as well, right? Reem, nice Reem. I agree that when you find this lesion, it could be like also from the mouth floor, maybe. And there is lymphadenopathy. So you agree with me that there is a lymphadenopathy, right? Left neck mass, contralateral lymph nodes, which is look like high uptake, and you can see here. Okay, and you can see this in the where the site here? Can you describe it? Yeah, it is a bony mets. Could you characterize the location? Right iliac. You remember our case last time? We take one case and we discuss it. It was long case. Do you remember? Try to remember and maybe it give you a clue. So here again, liver lesion, and it's high uptake in the BCT, FDG BCT, and you can see that there is again pulmonary nodule. So we have, I see Asma, welcome Asma, Rabab, Reem, Ala, yeah. So you collect everything and finally, yeah. So let's make a rule. There is a tumor when you find the lymphadenopathy. So it look like pointing to the source. So when you find the lymphadenopathy and you cannot find anything clear, then one of the silent location that it is not silent, but it look like a silent location with the review areas. You can consider it like one of the most important review areas in your practice. That when you find like lymphadenopathy in the neck, so search for the silent primary. The silent primary, it will be the oropharynx. Because if you remember, in the laryngeal tumor, it will present by some symptoms. Yeah, like in the voice, in the vocal cord, so it have something. Maybe in the nasopharynx, you will have also some symptoms clinically, and maybe. But the oropharynx, it present late. So take care about that. It could be like oropharyngeal tumor. And sometimes it's not big like this case. This case is late, advanced, but it can come to you like in early, and you can find lymph node and very subtle thickening in the oropharynx. Then your advice will be in this case that you advise your clinician that to take or to make endoscopy or oropharyngoscopy for this patient to check if they may have any tumors. So this one, it was otolaryngeal cancer, and is clearly here that there is something in the right otopharyngeal, right oropharyngeal pillar along the site of tonsil, maybe. Okay, and all this metastasis. You remember the last case we discussed in the last session? It was very similar to this one. Maybe it was again oropharyngeal, maybe it was laryngeal, but at least this one, it is biopsied and they have already like yeah. Okay, so do you agree? It is clear. Let's shift to another one. Oops. Okay, I think that maybe some of you see the diagnosis, but let's try to discuss. Already he tried to show you something here, and he tried to show you something here. And in the axial, he show you something here and here. So how we describe them? This is young female patient, already known biopsy, pathological tumor, and this patient did biopsy, yeah, and he take chemotherapy and radiotherapy, but he refused to take to make the surgery, which is radical neck dissection. And after treatment, he starts to make some restaging. Yeah, restaging. Nermin, smart answer. But then they will ask you to localize which type of pharyngeal. Is it like nasopharyngeal or oropharyngeal or laryngeal? So yes, it is nasopharyngeal. Perfect. Perfect. Yeah. So nasopharyngeal, and you can see here much easier. Again, sometimes you can see the Valdire's. We were talking about this case, and we discussed that the primary, it will be the nasopharyngeal, and it's sending metastasis to the lymphadenopathy, the lymph node in the level of the left submandibular, yeah. Sorry, the left level 2, and right upper lung, yes, right lung. So what he wants to show you here, yes, it is something in the larynx. So there is laryngeal tumor, and there is ipsilateral, or you can say left neck cervical lymphadenopathy with very high uptake. You can see that this nodule in the left piriform fossa with high uptake in the PET CT, and the MRI you can see the nodule, right? So this patient was, as you mentioned, it is laryngeal cancer or laryngeal, 60 years old male patient. The primary tumor, you can see here, this is the primary, and it sent lymphadenopathy with very high uptake in the left neck. And they like to mention the supraclav as a special entity. So also they involve the left supraclav lymph nodes as well. Yes, you can see them. Okay. What about this case? That's what I want to tell you, that sometimes the vocal cord, it takes, not sometimes, when the patient talk, like the normal talk, it can high uptake, which is like a normal. Like this is one of the pitfalls, that when you find the vocal cord with high uptake, as here, so this is normal, physiological, okay? So this one of the pitfalls when you see this appearance, okay? So that's why when you prepare for the PET CT, you will ask the patient to try to listen the talk, or maybe not talk, to not use the muscles of, and also the vocal cords and all the it can make the examination and make a lot of pitfalls in the examination, as you see here. So this patient have known history of something, and he already take treatment, okay, and make follow-up, and this one, it was the follow-up, yes. And you can see that the first follow-up he did after, for example, 6 months, he have maybe this lymph node, right? Do you agree? In the left side. Then when he did, like, after 3 months, it's follow up again, what happened here? Yeah. regression or stable or metabolic regression or metabolic progression or metabolic stability. What do you will choose? So it will be metabolic progression, yes. So this patient was nasopharyngeal cancer and he already treated by chemo and radiotherapy 2 years ago. Then when he did the follow-up, he showed that he have progressive disease, okay? And you can imagine how very small the lymph node here, and it can be missed easily. And when he did the follow-up, he make progression. You can see here very subtle lymph nodes, and here become progressive in course. Okay. So this patient, as you see, about 54 years old male patient, he have something, as you see here, and here. And you can see the focal uptake here. So in the regular, the esophagus can take some uptake. But when it is like focal uptake, it is not normal. So ألاقي mid esophageal high uptake in the esophagus. And there is again lymph node here in the right cervical lymph region. So perfect near me. So again, when you find lymphadenopathy, search first for the oropharynx. And when you didn't find something, okay. But when you find asymmetrical high uptake in one side, so it could be like oropharyngeal tumor. The mid-esophageal, as we mentioned, it can be just like esophagitis, especially when it is diffuse, or it cannot be something, or it can be suspicious that maybe another primary. So this is what we have here. It is oropharyngeal cancer, and this patient have lymph node in the right cervical region, and they put this focus in follow-up because it could be like suspicious for second primary. Yeah, that's what I told you. Sometimes if this patient have prophysis or have something, it can show you this high uptake. So maybe also from that, again, if he use his mandible, then the muscle of mastication or any surrounding muscles, it can have similar, yes. Okay. Let's have one more. What is the issue here? What do you think? Do you see any abnormality in the CT? Maybe this lymph node? So this lymph node, it could be metastatic. Yes. It could be laryngeal, maybe oropharyngeal. But when he did the PET CT, we find this one, which is what we saw here in the CT. But this is the like something in the PET CT, but is not present here. You cannot see it well, right? If you just look in the CT, maybe you cannot find it. Yes, Rabab, thank you. So it's the left tonsil. So high uptake in the left tonsil. And this is good example when the PET CT is very nice in this case, because you can see the lymph node and it's easy for you to detect the lymphadenopathy in the CT. But sure that if you did CT just, you cannot easily detect that there is high focus uptake in the left oropharynx. That's why when I told you that when you find lymph node, try to find the oropharynx. Start with it. Maybe it is the primary, if you didn't find any other primary, okay? So, and this is the benefit of this case, of the teaching point, in this case, Asma, that you didn't find anything in the CT, and this happened. Like sometimes you cannot find anything really in the CT, no density, nothing. So just the metabolism in this area is high, and this is what is called discordance between the finding in the PET CT and the finding in the CT. Then you, in this case, it will be like oropharyngeal cancer as primary. And this is the importance in this case to use PET CT to see the primary, okay? Here, is it okay for you to continue in this mode, or is difficult? I hope that is fine with you. Okay. So what do you find here if you try to describe what is going here? This patient have cardiac symptoms. Yeah, cardiac mass. Perfect. It could be a primary mass or it could be secondary mass, right? If it is primary, you will think about primary cardiac tumor, especially with this high, very high uptake. So what it will be, the primary cardiac tumor with very high uptake? Yes, Asma. But as we know, Asma, that in general, yeah, the cardiac uptake is very high. But you can see that here in the CT is very high, and there is thickening and there is soft tissue masses involving the septal wall and the, yeah. So sarcoma or angiosarcoma, it will be a good differential. Then if it is secondary, and there is also pulmonary nodules here, right? Okay, so it can be like one of the secondary, which is very rare, but it could be, right? So then the primary, you will search for primary. It could be this one, which is primary, could be, or could be this one, and this one could be metastasis as well. Then it will be hard for you to find the primary. Yes. So this patient have multiple pulmonary metastases, this one, this one, this one, and it have cardiac mass. So they make PET CT. Then maybe because now we start head and neck, so maybe you can suspect with me that there is something up. Yes. And this one, it was tonsillar carcinoma. Very, very rare, but yeah, this one, it have pathology and they prove it. So don't, in the PET CT, you don't exclude anything. You put your differentials, you try. I mean, for the regular, maybe you can consider this one. The largest one will be the primary, and the other will be the secondaries. And you will not look in the neck, which is not good to do this. But when you go up and you look to the neck and you see this high uptake in the oropharynx, then it could be one of them, especially if you get endoscopy and biopsy from this case. Okay. So again, tricky case. It's not easy one, but it can be happened. Yeah. As this case. Let's shift to another. Perfect. So there is superior vena cava mass. Nice. Nermeen. Perfect, Nermeen. So there is superior vena cava mass, very high uptake, reaching the right atrium with very high uptake. So again, it could be primary, it could be secondary. If it is primary, it doesn't look like a primary, but okay. Let's say that it's secondary. So do you have any clue that it can help you to see this primary here? No, I mean in this case. I mean in general, you can say anything, any primary here. But I mean in this image, can you find something, Asma, that can help you to find the primary? So this level of what? If you find, I see maybe Nermeen, yeah, tracheal. If it is not the trachea, what do you think? What will be the structure? Yes, Rabab, thyroid. So it will be thyroid. Then the discussion here will be that this PET-CT, and you know that the thyroid cancer, the main modality they used iodine, yeah, iodine or technetium, yeah. So why we show here PET-CT? I just want to take like point here that when you find the differentiated tumor, which is like the papillary thyroid cancer, which is differentiated, then the main diagnostic modality will be the technetium. So when you find like this cancer, which is take high uptake in this case, so it is de-differentiated thyroid cancer. This means that it have poor differentiation. Because of this issue, it takes high uptake. Is it clear? I mean, for the good differentiated thyroid cancer, it will show the uptake, but in the technetium. And here in the FDJ will not have maybe the high uptake. But if it is de-differentiated and it's aggressive one, then it will show you the, yes, anaplastic type. Yes, you get it, Nermi. Yes. So when you find the anaplastic type, which is de-differentiated and with its advanced de-differentiated, then you can see how this aggressive tumor, it can even make invasion for the superior vena cava as well. Yes. Okay. I know that is not easy, but we try to be familiarized with these cases. I will try to find easier cases than this. So again, the same. This patient did already thyroidectomy. He take iodine treatment, and after 1 year, the hormonal, the marker TG, he is increasing. That means that this patient need to be investigated. You can see that there is multiple cervical lymphadenopathy, and there is osseous, yes. And I see that there is bilateral pleural effusion, but do you agree with me that there is no uptake in this pleural effusion? So maybe it's not metastatic, right? But this high uptake, maybe it could be metastatic, yes. Yeah, I know that the fracture sometimes show this, but it can be metastasis as well. Okay, especially which is not site for the fracture sites. This is one maybe of the sites that it can be pathological fracture. Yes. So multiple cervical lymphadenopathy, osseous, and you get something in the liver, so it is also involving the liver. So this is again one of the de-differentiated thyroid cancer that it sends metastasis. Already the patient did thyroidectomy, but what we find here that we find the metastasis as a result of, yes, So this patient have multiple cervical, osseous, and liver metastasis of dedifferentiated thyroid cancer. So the main use of FDG PET-CT, it will be for the dedifferentiated type of thyroid cancer. Okay, is it clear? Then this patient is 64 years old, male, and he did CT, but CT was normal. But when they go in the neck, someone said that it's have something like lymph node here. So what do you think about this lymph node? It looked like with high uptake, do you agree? And maybe the appearance in the CT is not very nice, so it looked like abnormal, right? So is it really in the right vocal cord? Do you agree that it's in the vocal cord? There is some high uptake here. Yes. So when you find the vocal cord with high uptake, if I told you that the primary here will be like laryngeal cancer, it will be the left or the right? Sorry, if I told you that there is, sorry, the question would be, if I told you that this patient have vocal cord paralysis, which nerve will be affected, the left or the right? And sure that now he show you that there is diaphragmatic elevation here. Reem, Rabab, left. Everyone would agree with left. It will be the left one or the right one. Okay, so do you remember when someone asked me about the vocal cord in the previous case? It was having a high uptake, right? And I told him that this one is sometimes if the patient just talk, he will have this high uptake. So when you lost the uptake in the left side, this means that the normal uptake, it is absent. So the non-functioning, perfect. So when it is functioning, it will take high uptake like this one. And when it is non-functioning, it will not take. So the phrenic nerve paralysis here will be the left side. And this is one of the important questions in the exam when he want to test your knowledge. So this is left phrenic nerve paralysis with diaphragmatic elevation. There is absent normal uptake of the left vocal cord. Okay, and there is tracer uptake. So this one until now it was something called entity called cancer of unknown primary. Just he have this cervical metastasis and he have this left nerve paralysis. Okay, is it clear? Do you like it in the exam? Do you like it in the MCQ? Okay. Is it enough? Because I see that the dose today is for you is high, and I don't like to load you with this type of cases if it is not very nice. I will just try to show you if you okay. This old patient again have some lymph nodes. In the PET-CT, you can see that there is high uptake here. Yes. So if I told you that this patient, they don't have any primary cancer, and they search for primary cancer. Yes, Asma. So it is primary, it will be the larynx. and this lymph node, it is metastatic from the larynx. So this one is easy. You find the lymph node, and when you go to the uptake, you find it focal asymmetrical in one side, and you have already like something in the CT like nodule corresponding to it. So it is laryngeal cancer. Okay. Again, this patient have cancer of a non-primary. And they didn't know the primary. Yes, in this case, yeah, you have FG uptake again here and here. So this is which sinus, which, yeah, this is the piriform sinus. So you see the thickening here and the soft tissue as well with the high uptake. So I think it's easy now to think that it is coming from the left piriform fossa tumor, right? Okay, it's easy. I hope that can be easy with you. This patient did 2 PET CT, this one and this one. He already have a known primary. Yeah, there is axillary tick. So this lymph node. So if you find this axillary uptake, if I told you that this patient have primary and he treated, so what it will be? In your imagination, what it will be the first differential? Breast cancer, yes. So this patient did conservative maybe treatment and the conservative breast surgery, and he already have axillary lymphadenopathy. The next follow-up, he didn't have anything. So this one, it is easy and solved, that have axillary lymphadenopathy and he take treatment, whatever the treatment. Yeah. What about, yes, Ala, this would be my question. What about this uptake? Yes, this one. If I told you that, okay, I will wait, maybe someone can, yes, Nermeen. Perfect. So this site of injection, yes. So take care about it, because they like in the exam to show you something very simple in the VCT, that this one, it could be site of injection, and it is. It was, he take this recent vaccination in the right deltoid region. Yes. So this is site of injection. So this patient injection site. So yes, it is. Sometimes very simple to ask you a question and the answer will be again very simple. Reem, yeah, Ala, okay. We Marwa, Asma, okay. We have about 5 minutes to finish. Yes. So what do you think? There is left axillary. There is vertebral lesions. And in the CT, one of them, how we describe it, Is it lytic or sclerotic? Reem, which high uptake, which region? So this one is lytic, Asma, thank you. And there is maybe hepatic. So hepatic, osseous, and axillary. And axillary, yeah. What is your differential? Okay, I agree with you that maybe this one is this one. Yes, maybe. Yeah, at least we have osseous and axillary lymphadenopathy. This is what I told you before. This is the Waldeyer's ring. This is the normal appearance of Waldeyer's ring, that it have, because it is like have lymphatic tissue, so it have high uptake with this, like physiological uptake. You can consider it physiological. Rabab, yeah, it will be, the primary will be one of either breast or bronchogenic. So if it is not bronchogenic, then you can consider this point as retromammary or mammary point. So it is breast cancer, yeah, breast cancer. So they consider it as retromammary nodule. Okay. This in daily practice of PET-CT, you can see it in much patients. Osseous vertebral lesions with very high uptake. And maybe you can see the metastasis here everywhere. In the spine, the bones, liver, lung, lymphadenopathy. It could be lymphoma, leukemia. Then it could be lymphomatous infiltration. Or it could be metastasis. And if it is metastasis, could be breast cancer, yes. Yes, breast cancer, perfect. Okay. Again, breast cancer and metastatic where? So this is the breast cancer and this is the lymphadenopathy. So the metastasis in the left sacrum, yes, left sacral ala, and right axillary lymphadenopathy. Perfect. Then when this patient did follow-up, this is the second follow-up after he take treatment. Chemo and, yeah. So what happened is regression. You can see that the sacral lesion, it show regression, and the lymphadenopathy and the right breast lesion. Everything show regression. Nirmeen Asma. Yeah. So it's nice case that PET-CT, they use it even for follow-up, yeah, to know the result of treatment. Is it good, or they should change the management of this patient? So this patient did 3 PET-CT A, B, C. You already did surgery and chemotherapy. So if I told you that this patient was primary breast cancer and they did surgery and chemotherapy, so this one, what you tell me about it, is it negative or positive for metastasis? So this patient did restaging PET-CT here, and did you see any metastasis? So this patient have what is called recurrent disease, maybe in the osseous and left axillary, and maybe lymphadenopathy as well, and there is maybe lung. Sure that we need the CT and the axial images, PET-CT images to see where exactly, but at least you can tell that this patient have recurrent disease here, right? And when he did the second PET-CT, you see like regression or progression or stationary. Try to focus at least in the bone one, the bony lesions. Progressive, perfect. So this patient did progression. Have progression here. And what do you think about the last one? Is it more progression or regression? Yeah, this is in the colon, maybe physiological, maybe colitis. Yes. So more progression. So again, this is the rule of PET-CT here, that you see if it is baseline or maybe restaging. According to the stage, then after that you did follow-up and you see the patient after chemotherapy treatment, he's okay or not. So I hope everyone enjoyed today's session. I know that it's not very easy. If you have any suggestion, I will receive your feedback in the group, and thank you, inshallah. See you, and waiting for you in the group if you need anything. See you. Assalamu alaikum.